when a guy hears that maybe my sperm is not ideal, that's got to be kind of a blow to his sense of self and his feeling of manhood. That's psychologically, that's got to be a blow.
No, without a doubt. I never lose sight of the fact that we as caregivers are intrusion in the way that this couple wanted to conceive, which is in the privacy of their own home.
True.
And I think when the guy is at the forefront in that particular diagnosis, I think sometimes they withdraw a lot more than the female. The female, again, often will take charge in that circumstance. But the guy, just says, well, I'm disappointed, and maybe expresses that more in privacy to his wife than he does to us. So it's really trying to ferret out those feelings and making sure that we do acknowledge that we have not only some sympathy towards what's happening, but also that we have ways to help.
Exactly. And since you mentioned ways to help, what are some ways?
Well, we work, to me, I think the thing that a lot of patients don't realize is that when you're getting a specimen as a semen analysis, you're getting sperm that are anywhere from 1 to 90 days old.
Sure.
And so, as you know, when we make interventions, whether it be lifestyle modification, whether it be surgical procedure or medications, unfortunately, most interventions in medicine do not work like a lightning bolt. If it worked like a lightning bolt, we'd see our best response in 90 days. But more often than not, it's like a snowball gaining size and momentum going down a hill,
right.
And it's going to take probably 2 90-day intervals at minimum before we have to call it and say, did we make some progress? So I think the first part is education. And the second part is working in concert with urologists. I don't really try to duplicate what they provide. I'll in general not write for medications because I think it's important to work in concert with urologists and their expertise in helping these patients. So let's say that either there's not a pathway in terms of something simple to help the guy or perhaps a procedure to help the guy in
Sure.
the concert with the urologist, or they just feel like their family planning goals dictate that they need to try something sooner, or sometimes they'll even hit my door having attempted some of those interventions. Then probably the more common things we do are intrauterine insemination, in vitro, and sometimes in concert with in vitro, we do intracytoplasmic sperm injection, or ICSI. So these are the more technical procedures we do in the context of our office and our laboratory to help get a couple together.
Talking about some of those more higher tech procedures, there's been some news recently, and I'm sorry I didn't give you this question in advance, but there's been some news recently about how some of those procedures may affect the health of the children that are born with some of those procedures. From your perspective as a reproductive endocrinologist, what kind of conversations do you have with couples about that?
Well, it's interesting. When Octomom hit the airwaves.
Oh, yes.
I didn't go a half day without hearing about Octomom. And lately, since the news article you mentioned,
yes.
and it's been kind of put out there by the Associated Press, has been propagated, I get that question a lot. And in particular, my patients, when I'm contemplating doing IVF with them, I'll do a one-on-one conference with them and go over what IVF is. And inevitably, that's when it comes up. And I think the way you have to look at it is that this isn't really new information.
Correct.
I think we've known for some time that the disparity in anomalies or birth defects, and some of these, again, are not life-threatening birth defects. I think whenever we hear the word birth defect, we think horrible things.
We do.
And inevitably, that can be something as simple as webbing between the toes, skin tags. Those things would still count. Inevitably, I think those are all lumped together. But keeping in mind that there are some more serious conditions in that realm also, when you look at the term that I don't like because everybody's normal in their own way, but fertile norms, couples that are having no difficulty getting pregnant, and you compare them to age-matched peers who are seeking fertility services, what we've always known is that there's a slight increase in the risk of birth defects that we can't explain and probably is due to some innate problem in either the egg sperm or the combination thereof. What's interesting in the newer data is that we're thinking that ICSI slightly increases it a rung beyond that. And, we are pretty liberal in our practice as to who we use ICSI with. And, we generally have a low threshold for adding it if there's any kind of male factor or unexplained infertility. And so that question inevitably comes up. And I've even had patients say, well, do I have to do ICSI? And the way I look at it is that inevitably across the board, what you're tolerating is about a 1% increased risk of anomalies compared to traditional fertility therapies, if you really kind of try to quantify it. And if that adds, 10, 20, 40% increase in pregnancy rate, that's a risk you might want to assume. That's the way I look at it.
I think that's a great way to look at it. We're up against a break. I hear the music. Dr. Kenneth Moghadam from Austin Fertility Institute. We're going to take a short break and be right back with more.
Then when we find out to him we belong, we watch for the signs and keep sailing on.